Hello, how are you? Thanks for having us. My name's Aaron Harvey, and I'm here with Adam from Spring Health. And today we're going to talk a little bit about eliminating the guessing game to actually getting to meaningful treatment and care for mental health, and how to use media, science, and data to do that. There's a lot of old school studies out there that say, it could take 10 years or 15 years or longer to actually seek proper psychiatric care for a mental health condition. That's something that I'm super familiar with. This is why I'm in the chair today. But really in the last 5 or 6 years, it's just exploded on social, our access to information, our ability to quickly search symptoms online and find very deep information, very specific information, like fear I might harm my baby. What does that mean? This is popping up right now for the first time in my life, holding my newborn. And so I think for us, it's like, how do we actually go from that point where someone has that symptom onset and get them into that proper care? So so I think we could just start with the intros. If you want to just tell us a little about why you're passionate about mental health in general and kind of what your personal journey, apart from even Spring, has been to get to this point.
Yeah, so my name's Adam. I founded a mental health company called Spring Health. We partner with large employers and health plans to help them eliminate every barrier to mental health. I actually came to the US to get my PhD. I went to Yale, worked in the psychiatry department, and just to back up for a second, there are lots of problems in mental health, and so I think sometimes you kind of have to pick a lane and decide which little piece of mental health you want to solve. And so for me, I was at Yale and I was hanging out in the psychiatry department and talking to psychiatrists, and certainly many of you in the room will have gone through this, if not a friend or a family member. But even when you get into mental health care, the problem is nowhere near over, right? You've experienced kind of the trial and error and the guessing game that goes on the diagnosis side. Even once you have a diagnosis, there are still dozens of different treatments that a psychiatrist can do. And so, hanging out with psychiatrists, they would say things like, oh, yeah, there are so many different treatments and you just have to kind of see what goes on, right? They kind of use their own clinical intuition, and they'll say things like, let's start with Lexapro. Or they'll say, okay, let's try therapy. And even amongst therapy, there are dozens of different kinds of therapy, and they feel very different. And some people respond really well to one kind and not another. And so my time in grad school was really focused on that problem of trial and error, right? What if there was a way where instead of saying, let's start with Lexapro, we could say, let's take a moment, let's learn more about the problems that you have, and let's try and figure out what treatment is going to work best for you, you specifically rather than you on average. And so Spring, that line of research went really well. We published all these clinical trials in places like JAMA and Lancet. And we had this technology, and it was a real opportunity to help people figure out the care that was going to work for them, to try and shortcut this trial and error and shortcut this guessing game that goes on for people when they were getting treatments for these common mental health conditions. And so we founded Spring. The whole point of Spring was really to take this technology and put it into patients' hands and help people be able to accelerate their own journeys, to accelerate their own journey to recovery, right, even beyond access.
Yeah, and so for me personally, I'm a co-founder of the Mid-Millions Foundation, and our mission is to change how the world perceives mental health. We focus a lot on that bridge between awareness of a symptom or an experience, and then actually getting the psychoeducation that you need to then be able to get in the proper care and navigate your care in a very broken sort of landscape. Like you truly have to be in the driver's seat of your own care. So we really focus a lot on the psychoeducation, and kind of for me, like, the most important thing is bringing the science with the lived experience side. And going back to even when I was 8 years old, I started having intrusive thoughts about, super taboo topics, killing family members, violent thoughts, flashes, hundreds, thousands a day. This really affected me for over 20 years. It led to a lot of really debilitating behaviors, challenges with substance, self-harm, suicidal ideation constantly. Meanwhile, I was kind of living this double life and building a creative agency in New York called Ready, Set, Rocket, and got to the total breaking point, at South by Southwest, a handful, it was 2014, and I just was completely done and beyond kind of that ideation stage. And I think in that moment, I finally Googled violent thoughts, and it's such a scary, simple thing. I run an agency, help make the internet, but I would never search violent thoughts because it's an admission that something might be wrong. And that over 20-year period that took place, like I said, it's just a total decline. You get so many comorbid conditions and negative experiences come into play. And that's why I'm passionate about, what we do and finding that bridge between lived experience and then, like you said. So I spent a lot of time just being a guinea pig and then trying to, figure out kind of what that path was to sort of help others eliminate that guessing game. So I think with that, building on what you were saying about building on what you're saying about like doing all these clinical studies in school and then getting to that insight where you could take a different approach. I think, I'd be just super curious to hear a little bit more about why you focus on the workplace and working with employers, and then kind of a little bit more about, the problems you're solving both on the patient side, but also on the employment side.
It's awesome that you persisted through treatment. I think all too often, like, people face those barriers, and even when you pluck up the courage to go and get care, then you just get faced with, insurance, in-network, out-of-network, co-insurance, deductible, blah, blah, blah. Accepting new patients, not accepting new patients, and too many people, I think, fall through the cracks with their experience, so it's awesome that you didn't.
Nice.
Yeah, I'll answer the second piece. So kind of the idea around the idea, trial and error is a thing in mental health care, right? But providers don't want to do trial and error, and often they're trying to shortcut trial and error through things that they've learned through their own practice, right? And so a good example would be things that they might learn in school, in med school, depending on where they did residency, or things that we know in the literature to be kind of true, right? A good example that I often give would be if you are presenting with depression and you also want to quit smoking, then there's a drug called Wellbutrin that is often used for both of those. And so psychiatrists might say, well, okay, well, if you want to quit smoking and you're also depressed, then maybe I'll use Wellbutrin. And so that's just one example of psychiatrists trying to personalize their decisions that they make for treatments for an individual patient. And so the clinical work that we did was basically taking that concept, but kind of bringing more of a big data approach. Rather than doing it just based on one thing, like whether you want to quit smoking as well as being depressed, what are all of the things that we might be able to consider, right? Is it to do with your eye color? Is it to do with whether you have tattoos or not? Is it to do with your employment status? Is it whether you've tried Celexa in the past and it didn't work? Is it whether your parents had bipolar disorder? There are all of these different things that could influence treatment decisions. But you'd never know really which one is, and certainly an actual prescriber, there's no way that they can ask all of these things and kind of juggle all of those different parameters in their head. And so what we did was we would partner with all of these pharmaceutical companies and the Food and Drug Administration and large academic medical centers and kind of pull together all of these different clinical trials and then train machine learning algorithms that would look through all of the data that they could find and try and make statistically optimal decisions about what kind of treatment was most likely to work. And we found that when people did that, they were about when people went and actually, did this assessment and we personalized those treatment decisions, and then they took the treatment that was recommended, they were about 2 times more likely to get better. They got better about 8 weeks faster on average, reducing down from 20 weeks on average time to recovery down to about 12 weeks. And so that was kind of the clinical approach and the technology that we had. There's a separate question of, healthcare in the US is very complex, and what is the right go-to-market approach that you can have. It's actually kind of a complicated story. We initially tried to sell to health systems, and that was a good example of, we went into sell to health systems thinking like, okay, well, if we can make these decisions better, then we should go to the place where people make those decisions all the time. So we would go to these health systems, the ones who are prescribing all of these treatments and delivering all of this care. But actually the incentive structure is not quite right there, right? Really, the health systems actually make more money if the patients stay sick. And if actually the patient gets better faster, they now need to go and spend more on marketing to go and get new patients, to go and fill those slots for all of those patients that are recovered. And so, we kind of had, we had some challenges, certainly with the go-to-market selling to health systems. And that was actually when early in Spring's kind of history, we pivoted over to sell to employers. Employers in the US, some of the largest healthcare purchasers in the country, and about half of the US, just under half of the US gets their insurance through a commercial, through their employer. And all of the problems that we'd faced on the health system side kind of went away with the employer. The employer was actually like doubly incentivized to reduce guessing in care and to help accelerate recovery, because on one side, yes, they pay the bills. So if it takes you less time, or you consume less care, or you can get better faster, then that's better for them because it would cost them less money. But also in mental health, about half of the cost of mental illness is actually on the workplace side, the things like productivity, things like absenteeism, things like short-term disability. And so employers would actually save twice. They can get all of those benefits of people being more productive and happier and healthier in the workplace, and they can also get the financial, total cost of care benefits. And so that pivot into selling to employers was, it was certainly scary at the time, but that's kind of what was going on in our head when we decided to make that pivot. And since then, it's been really great.
Yeah, and I just think we were kind of doing the same thing as a charity because we focused a lot on first building a case study around obsessive compulsive disorder, which is what was experiencing, which most people don't understand because there's a branding problem around that, and then bringing that out a little bit further, and now taking that case study of success around that and building out across like a lot of different conditions. But at the end of the day, we are not learning in school what any of this stuff is. We have no idea. It's all just the fear of the symptom onset, the secretive, searching and things like that. So in a parallel path, we also as a charity really started to focus on the workplace because to us, that was the number one way to cut the timeline down. If, your organization partners with, someone like Spring and there's a symptom onset for the first time that they're disclosing in there, that's actually an immediate intervention opportunity there, which cuts that time down so much. And so we've done a lot of things like more on the campaign side, like using media, like creating campaigns like Dear Manager, getting the ad industry behind it, building a workplace training education platform that focuses totally on psychoeducation and being able to license that out and overnight train 10,000 people working for a big media company on what's an intrusive thought, what does it mean, and so that kind of stuff for us is super important on the media and like the knowledge sharing side. So I'm curious, as you're scaling, which obviously there's so much demand right now with the increase in the conversation around mental health, there's so much demand for services, and there are supply issues. How are you balancing both the opportunity and really the market need to scale to help people, and doing that in a way that's controlled enough and supported by content and care teams and all these other types of things that you guys have integrated beyond just one-to-one care?
Totally. I'll answer address the first thing that you talked about, the stigma that goes on with mental health. I mean, you heard in the last panel, there's barely any sex education in many places, let alone mental health education. And so it's awesome that at least at the employer level, whatever we can do there to kind of correct some of those stigmas and to kind of educate people on what mental health is and what it means and the treatments that are available for it and just the reality of how care works and the life that people can live again afterwards, it is so important. And so it's awesome that you guys have been leading the charge there, and I'm very grateful for that. The second thing about scaling, I think we've kind of had, the technology has really helped us, right? I think if you think about scaling traditional care, you're really scaling a broken system, right? Like if you take a fundamentally inefficient system where people don't get the right diagnosis and they don't get the right care, then ultimately scaling that is going to be hard, right? And whatever we can do to make care more effective, whatever we can do to accelerate that time to recovery, ultimately has a very big impact on your ability to scale down the line, right? So if you take, for example, even just us versus a leading competitor in the data that we've published in both of those, we've published in leading medical journals, they've published in medical journals, our time to recovery in terms of the number of appointments that people take is usually somewhere between 5 and 6 appointments on average, and in their peer-reviewed data, it's somewhere between 9 and 12 appointments on average. And so if you just think all else equal, if it takes you twice as long to help get better, that means that you really need twice as much supply. So if you're going to go and care for 1 million people, they're going to need to have 2 times as many visits in their system, or that's how much capacity they're going to need to be able to effectively deliver the care that those people need. And so I think when we think about scaling challenges, certainly it is difficult to scale a hypergrowth company, but I think that you really have to kind of think back to what is it that you're scaling? Like when is the right time to scale it? And are you scaling something that can be scaled in an appropriate way? And I think that for us, that was kind of, there's a lot of talk around access, right? Like we need faster access, we need faster access, we need to put the networks online, we need to be able to book appointments and find providers and all this kind of stuff. But ultimately, if those providers, fast access to the wrong kind of care for you is ultimately meaningless, and you're kind of scaling something that's not going to be a true solution.
Yeah, I mean, it's so critical that you can bring a lot of different data points and a lot of just different intelligence and then change the way that it works. A lot of people in our community that we service are people all over the world. Misdiagnosis is so rampant, and it literally leads to involuntary lockups. It leads to just a total debilitation, and then also just a lack of will as you're kind of going through the wrong process. So For us as a charity, we have to be very agnostic. We don't take, we haven't taken money from, you know, platforms or tech companies or things like that because we've just tried to be really true to be able to evaluate and hopefully be a voice of honesty or truth um, on behalf of a community that is largely being capitalized on in a lot of ways. And one thing that you did recently, which I think is a really positive um, positive thing in the right direction, was not just publishing based on like hype and growth, but also you guys did a big study recently that was peer reviewed and over a very long period of time. And I wondered, I know you shared a little bit about that, but I want to just emphasize that point of like actually, for-profit corporations doing truly peer reviewed scientific work to then validate and continue a process. So I don't know if there's anything insight in there in particular that, you wanted to pull out or just anything you want to share on that topic.
Yeah, totally. Ultimately, Spring and many of these companies, like we're kind of tech companies, right? There's an element of which we are a tech company. We're doing something different and using software to try and to make healthcare better in some way. But you're still fundamentally a healthcare company. And the currency in healthcare and the currency in medicine is peer-reviewed evidence, right? When Pfizer goes and makes a vaccine or Moderna goes and makes a vaccine, they have to do a clinical trial and they have to go and publish that clinical trial, and hopefully it goes to a really strong journal that goes and finds all of the experts in that field in the world and shares all the data with them and has them evaluate it and make sure that the methods are sound and the analysis was appropriate and that the conclusions are reasonable given the data that you have. And I think that that mental health companies have gone a pretty long way without showing the appropriate evidence that they should be, given the severity of the issues and given the reality of the issues that people are facing. Like you said, you talked about some of the symptoms. More people died this year the stat was true in May. I don't know if it's still true, but I saw the stat that more people had died between January and May of opioid overdoses than COVID. I mean, mental health is a huge problem, and it's a highly mortal issue in many cases, and many people are dying of it. And so I think that all of those factors and kind of this long tradition in medicine that peer review is kind of the currency, peer-reviewed evidence is the currency in healthcare and medicine. I think that the same applies absolutely equally in mental health. And so, recently we published all of Spring's data from 2018 to 2021. I think it was about 3 years of data that we had, all of the patient-reported outcomes we had, all of the provider outcomes, all of the workplace productivity and absenteeism and disability data that we had, and submit it all out to a journal, and it goes out to peer reviewers. Went in to a journal called JAMA Open. JAMA goes and invites in all of these peer reviewers who are experts in mental health or workplace wellness or well-being, statistics, that kind of stuff, and they go and they evaluate all of the data that you have and make sure that the conclusions are reasonable given the evidence that you have. And we'll continue to do the same thing. I hope that it encourages other mental health companies to do it, and I certainly have seen other digital health companies continue to do it. It's not going to go away, and I think it's the right thing to do ultimately.
And just curious, how do you see your role as an organization in the overall thought leadership of the industry? So you're doing these types of reports. You also have a lot of tons of proprietary data that you're getting from all these employers, all these employees, all these different data sets that are coming in that are obviously informing your product. But what are maybe some ways that Spring will invest in that sort of thought leadership angle from an industry? Like how can you raise the whole industry up from a intellectual property perspective?
Yeah. I think that the publication is a great example, right? Like now, when an employer is faced with the choice between 2 or 3 different mental health programs that they can implement, it's a pretty reasonable question to say kind of what is the evidence? Is this peer-reviewed evidence? Is this really gold standard medical grade evidence that tells us that this is going to be safe and this is going to be effective for our employees? And so I think that just by us doing that, it kind of raises the bar, and now other companies will have to do that. And employers will be educated on the importance of that. And so I think that it's a good thing for the field overall. It will push everyone to be more rigorous and more disciplined about publishing data and doing research to show the effectiveness of what they're doing. So I think that it's going to make a big difference. On the other side, certainly a lot of what we collect, a lot of the data that we collect is proprietary. I think you can improve knowledge in the field even when data is kept in a proprietary way. Mm-hmm. There's things like patents that you can do that would give you protection over the intellectual property, but you can still have a patent and also publish something. You just have to kind of file the patent beforehand, and then you can publish it, and it can still go through peer review, and other people can still learn from what you did and how you did it. Patents themselves, remember, once you publish it, once you submit the patent, the application is public and people can go and read it as well. So the whole point of patents is also to give you some protection over the IP, but also to help everyone else understand this is what they did, this is how they did it, and so for other people to build on it. And so I think that it's good for the field, and we will continue to be open in that regard. I think we'll continue to publish the evidence on the effectiveness of what we do, and I think we'll also continue to publish research on the proprietary things that we do. Some of the, we're working on stuff right now around pay for performance. I was telling Aaron backstage, all of the providers in our network all use kind of the systems and the tools that we provide to them, things like electronic health records and scheduling systems and all of the medical legal infrastructure. And we aggregate all of that data and actually give it back to the providers. Every month they get a report, they get this coaching, really specific, really actionable feedback about the care that they've been delivering and what was working and what was not working and kind of how they stack rank compared to all of their peers in the network. And then at the end of every quarter, we actually pay them for performance. And so the best providers in our network, the providers that are delivering kind of the highest remission rates, at the end of every quarter get the biggest bonuses, and kind of a strong retention tool for us to be able to continue to retain the best providers. And it's great recognition for them because they get monetary and non-monetary recognition for the quality of the care that they deliver. That's a great example of something that is proprietary, but we'll still publish it. I think it's important that everyone understands that you can have a value-based system and a pay-for-performance system in mental health, and we've got great data showing that it increases the quality and it increases the member-facing clinical outcomes when these providers have coaching programs. And so I think that that's a great example of where you can have something that you can still develop things and you can still share knowledge, and it can still be valuable for you as a business, and it can still help the field in general.
Yeah, that's amazing. And I mean, I think as we just kind of close, I would just say that something you said earlier about picking a lane.
Yeah.
The topic of mental health is obviously so overwhelming, and at Made of Millions, like, it really is a grassroots movement. No matter what your job is, your skill is, your passion is, you're a stay-at-home parent, anything, there is a lane in which you can lean into to take what your personal experience is and help elevate all the work that we're doing from nonprofits to for-profits. So I would really encourage you at any point to join in the movement that we're trying to make as a total industry. So thank you.